Okay, so welcome to today's CPD webinar. Today we have a really, I suppose, hot topic in radiation oncology. It's going to discuss sex as a biological variable. So I'm delighted to chair this session, and this topic is really gaining, I suppose, momentum as an area of interest within the radiation oncology community. So it's very timely to have this talk on our CPD webinar series. So during the talk and afterwards, please feel free to use the Q&A box. The chat doesn't work on the webinar thing, so just pop any questions into the Q&A box and the speakers can answer them at the end. And we're really lucky today to have two experts in this field speaking. So first up, we have Professor Laure Marignol. So Dr. Marignol is a professor in radiation therapy. She's a radiobiologist at Trinity College Dublin. She's fellow of TCD and the head of research and the head of discipline at the discipline of radiation therapy. Her earlier work focused on kind of prostate cancer, and more recently she's been investigating the impact of biological sex in radiation therapy, looking, I suppose, particularly at bladder cancer, or mainly at bladder cancer. And we also have Dr. Henry Park, who is a board certified radiation oncologist at Yale Cancer Center in New Haven, Connecticut. So he specializes in lung cancer and head and neck radiotherapy. And in addition to his clinical work, he has academic links with Yale School of Medicine, where he's an associate professor, he's vice chair for clinical research, and he's the chief of thoracic radiotherapy. He is joining us for the second half today. And we're very lucky to have him here today as well. So I'm going to hand over to Professor Marignol first, and then Dr. Park will take over afterwards. So thanks, Laure.
Thank you, Sarah, for the lovely introduction. So everybody is very welcome, and for people that will be listening, I'm delighted to give you an insight into the issue of sex as a biological variable in radiation oncology, and this is part of our webinar series that you can find every month online. So I will structure my talk around defining what is a gender bias. We'll then look at the distinction between gender and sex, and then we look at the sex and biological variable principles, and finish on a discussion on or evidence that it might matter in cancer and in particular radiation oncology. And that will be a nice introduction then to the second speaker today, which will tell us a little bit more about the clinical relevance of this of sex consideration. So I'll begin by talking to you about the gender bias in clinical practice, and I've used an example and a couple of slides that were kindly provided to us by Professor Joel Schwartz, who came to visit us a couple of years ago and gave us this very nice example. So they did a very nice little exercise with clinicians where they first gave them a little synopsis of a case scenario where the person was a man. And they told the clinicians, you're dealing with a 43-year-old smoker, it comes to consult for sleep disorders for more than 6 months. There's a difficult situation in work. They are divorced, they have 2 children. They're really struggling to concentrate, and they have a lot of worries and anxiety that is really having an impact on their quality of life. They're constantly agitated, physically tense, and complain of tightness in the chest. There is no suicidal risk. And they did the experiment by giving this synopsis in relation to a man, and then did it again, and this time it was in relation to a female patient. And then obviously there was a cohort of psychiatrists, I think at the time, and they offered 4 options of what they would do for this patient. So first, they could maybe choose to give a regular psychotherapeutic follow-up. They might prescribe an anxiolytic, something against anxiety, and see the person again in a week. They might initiate cardiological investigations, or they might again give, the first one was an antidepressant, there was one an anti-anxiety tablet. And then they scored what people picked in the audience. And you can see from the graph on the right that whether they were dealing with a male patient or female patients, the decision perhaps was slightly different. And you can see here that shows an example of how we might be a little bit biased from the clinic side, depending on what we have in front of us, whether it's a male or a female patient. So why is there a gender bias in medicine? It's because medical knowledge is built on an androcentric model. In fact, for a very long period of time, women were excluded from medical research for a number of reasons. And in 1993, the NIH revised this and published the Revitalization Act and decided that women and ethnic minorities should be included in research. And from that stemmed the NIH sex as a biological variable policy. And since then, we're starting to see a lot more presence of female patients in clinical research. And I suppose that has generated data that we might feel might be more applicable for male and female patients. But in recent years, there's really been a surge of putting gender on the agenda. And I pulled this slide here from an article in Nature that was published. And you can see that the gender issue is prevalent across many fields of medicine. And in particular, you can see a highlighted cancer. So really, there is a very big interest at the moment to consider gender in our studies and our medical research. And really try to understand, are there differences between the two sexes? The reality, and we were not the first to show this, is that in medical research, despite the policy in the NIH, there is an underrepresentation of female patients. There is a lack of reporting of sex in cell line studies, in animal studies, and really, despite best efforts and advocating for this, there is an imbalance, and we still tend to do research on male patients, and that could be a problem moving forward. I think it's important within the context of a sex biological variable policy or principles in research, and also in terms of what I'm going to talk about in our own experience, that we define the difference between gender and sex. So genders tend to be self-identified, and it is linked to bias in gender blindness, where we feel that there is no clinical relevant difference between men and women when in fact there might be. And there might be some gender stereotypes where there are differences between men and women when there aren't. So we think there will be some, but they don't exist. And the distinction between gender, which is a socially constructed role, that's how the person identifies to a specific male or female traits or another gender, in contrast to sex, which is the biological attributes of humans and animals and the way you were assigned a sex at birth, which is linked to your chromosomes, your XY if you're designated as male, and your XX sex chromosome if you're designated as female. And there is a big distinction here to be very cognizant about. This gender bias is an interesting concept, and it's something actually you can test yourself. And I put a link here to a simple test you can do that allows you to perhaps test whether you do have a bias somewhere that you may not be fully conscious about. And it's actually very common that this test will show that we do tend to have a bias. So what does the sex as a biological variable principle entail? Well, what the NIH was always pushing researchers to do is to consider sex, so design studies that take sex into account, and if they don't, explain why it isn't incorporated. And it's a very common question nowadays in, for example, grant applications. The second asks that we collect data and we tabulate them based on sex, so that we try to separate our data sets according to whether we have a cohort of male patients or a cohort of female patients. And that we go and characterize or analyze our data in a sex-based manner, so that we again segregate our cohort and repeat our statistical analysis to see if there might be difference or if an effect might be more attributable to one sex over the other. And importantly, that when we communicate the results of our research, that we are cognizant to reporting and publish the data based on sex. So sex has to be considered across all the different steps of the research, and that's the best way to ensure that we end up with data that is relevant or that is cognizant of the fact that the patient population is composed of male and female patients. And why do we need to do this? And what happens when we do this? Well, when we start to analyze the impact of sex, we do find differences. We are have a lot of evidence that some malignancies are more common in males compared to females. And when we look at outcomes or how well these patients are doing after treatment, there is an argument here as to whether sex could be a negative factor for some patients. For example, female patients have been reported to have worse survival outcome after surgery when they have bladder cancer. And we'll hear a bit more about the second study that I mentioned here, which is a female patient with smaller lung cancer, perhaps have a better survival outcome after conservative thoracic radiation oncology, radiation therapy. So whether your patient is a male or a female assigned could have an impact on how well they do. And perhaps this is a piece of information that we need to be careful in handling or at least testing in our research design. Of course, you will find in the literature a little bit of conflict out there. So for example, in the example of bladder cancer, there are studies that show that sex perhaps doesn't have an impact. And it can be very difficult to be absolutely certain. And the reason for that is that it's multifactorial. You could have a lot of arguments to say, well, it could be a social factor, it could be the time of diagnosis, it could be age, it could be other things. But despite all of that, and some studies have tried to correct for all these factors, and still they do find a difference between the sexes. So there has to be, underneath all of this, some element of biology, genomic and mathematical reasons that we need to really drill into to answer those questions. A number of people or researchers have actually applied the NIH policy and really looked at sex differences, and there is a wealth of information out there that really show sex differences in cancer mechanisms. There's a lot of reports that we have sex-biased molecular signatures across a number of cancers. We see reports of sex-biased pathways, and the big one is the immune response. There are also sex different in the apoptotic pathways, DNA repair. And very intriguingly, we find that the sex chromosomes themselves don't behave as expected in a cancer scenario. What has been described is that men may develop a tumor that loses its Y chromosome. We see that in female, we have a reactivation of the X chromosome in tumors from these female patients. There's been some links between the X chromosome and chemosensitivity. There's some links between the Y chromosome and cancer and immunity. And really, there is something happening with those sex chromosomes in those tumors that perhaps warrant further investigation and could help us understand how treatment outcomes better, or perhaps help us individualize treatment in a better fashion. And it's something that our group has really been interested in focusing on, and we chose bladder cancer because a lot of talk about the impact of sex in bladder cancer, and there is this notion that perhaps a sex gap exists in bladder cancer care that we need to be careful about. Our lab is really focused on the sex chromosomes, and here you have a subset of data of X chromosome genes that we analyzed using the TCGA database, and we looked at male and female patients, and we looked at their matched normal and tumor tissue, and you can see on this graph that we find that a number of genes located on an X chromosome are differentially expressed in tumors compared to the healthy tissue for these same patients. So that opens up some question about what do these genes do. We pull out a subset of these genes, and when we run Kaplan-Meier curve with data that is available, we can start to see that they might be important because we can relate them to survival in men and female patients. The Y chromosome is a very interesting one, and it's one that probably has been a little bit more studied than the X chromosome at this point in time. And we screened the Y chromosome genes. We screened 41 of them. There's about 70 on the Y chromosomes. And again, we saw some significant differences between the expression levels in tumors compared to the adjacent healthy tissue in these men. We screened the genes and we found 23 genes. And again, those were correlated then with survival in the survival data that was available to us. And we found that the high expression of these Y-linked genes was likely or correlated with a higher level of survival. Now, we don't really know the meaning of this at the moment. It's something that needs to be further investigating, but it's raising some interesting questions as to what do these Y chromosome genes do. We've begun to look into this by studying a correlation between the Y chromosome genes and the DNA damage repair genes, because if we want to look at treatment response, disease progression, we know that DNA repair is an important biological process. So we were kind of wondering, could those genes influence the expression levels of DNA repair genes? And we've done those correlation studies again in this data set and found that yes, indeed, quite a number of genes appear to be correlated. And we are in the process of dissecting this information and testing the hypothesis that the genes that are located on our X and Y chromosome in male and female patients can influence how our DNA repair genes might function. So what is next? Well, there is no doubt in the literature that once we try to segregate data between male and female sex, we can start to see differences and we can start to perhaps uncover novel mechanisms. And that advances our understanding of cancer and ultimately understanding of response to treatment. Of course, there are a number of challenges. We all know that sex is not binary. The sex chromosomes of the patient do not always match those of the tumors. And one of the limitations of the databases that we might have access to or the samples is that we don't necessarily always do a karyotype to check the presence of the X and Y chromosomes or check the balance between the two X chromosomes in female. And that's perhaps something that needs to be more incorporated into data collection. There is the whole area of circulating hormones levels that is very difficult to control for. We know that the hormones are not sex specific. And if we are to really apply sex as a biological variable principles, we're going to need a lot more patients, because if you're only going to analyze your data in a male-only cohort or a female-only cohort, then you're going to need a lot more of those patients to do that. And when it comes to genomics, there are some limitations here in the way the data is handled that might need to be overcome to be really better at correcting or accounting for sex in those data sets. So there are a number of things that are actually actively being researched as we speak, but that will need to be overcome if we are to truly, fully understand the impact of biological sex in cancer and cancer treatment. We've done a little bit more work on this, and we have also looked at lung cancer. And we focused on the YBX1 gene, which is a gene we had an interest in. And our question is if we want to relate this gene to overall survival, and we don't separate the cohorts into male and female, or we don't take sex into account, might we get a different answer? And we did find that when the data was a mixed populations with both sexes, we might have concluded that this gene had no relationship with overall survival. But when we segregated the cohorts, there was a pattern that perhaps it was actually different between the male and female. And that's really, for us, was further evidence that it's really important to analyze our data in a sex-segregated manner. Lung cancer is another really good site to look at sex disparities, because we know that there is a difference in incidence between male and female. We know that females have an increased risk of lung cancer, especially if they're young and they have never smoked. And there is a sense that perhaps female sex is a positive factor, so perhaps they do better if they are female or female sex. We have looked at the X and Y chromosome genes in these cohorts, and also, again, showed that a high number of X-related genes and Y-related genes appear significantly altered between tumor and adjacent tissue in these patient cohorts. And that raises the same question as I just discussed in bladder as to what that might mean. There's effort, if we bring this back into radiation oncology, to suggest that we need to really focus on sex a little bit more. And this really nice study was published recently, or in the last, in 2020, that made a very valid point here that there is likely to be an effect here, but it's under research. There is some evidence that radiation may induce damage in a gender-specific manner. We do see studies reporting differences in incidence in some radiation-induced toxicity in mice, and there was a suggestion that this could be linked to level of estrogens in these mice. And looking at patient data, and we'll hear a bit more about this in a moment, when we separate by gender, in these studies, they did see a big difference in the dose that will reach cardiac toxicity, for example, in this particular study. But the problem is that we still are very poor at incorporating women or balancing our studies to incorporate both sex appropriately to really answer the question of sex. So often our studies remain poorly powered to actually detect a sex difference. So you might see studies where they say there is no sex difference, but when you look at the patient data characteristics and how the cohort is constructed, one might be arguing that they just didn't have enough patients to be able to tell. And we did a small analysis a few years back of the literature, as we had done in bladder cancer, and again showed that in studies that were looking at radiation response, being cell lines, animal or clinical studies, in the subset of studies that we randomly picked, there was an underrepresentation of female cell lines or animals or patients, and there was an underreporting of sex in the data analysis. So to conclude, there is evidence out there, but it's still probably quite small, but it's likely to grow, that identical radiation dose, in fact, may affect one sex over the other differently, and we need to perhaps use that to better our treatment. This could have implications for outcomes. It could help us personalize care, and it might mean that we need to follow up patients differently, depending on whether they are the female or the male sex. So I hope I've convinced you that the evaluation of sex as a biological variable in radiation oncology is warranted, and that we hope to see a lot more studies coming through investigating this effect in more detail. And one thing that we could do is revisit our data. So maybe we need to go back in time into the data that's sitting out there and reanalyze it more carefully in terms of male versus female to see if there is a sex effect there that we perhaps have missed in the data to date. So on this, I'll end here and hand over to the second speaker, and perhaps we can take questions at the end when both presentations have been complete. Thank you very much for your attention.
Thank you very much. You can share your screen, I'll share mine. All right, thank you very much for the invitation to speak today. I'm looking forward to this. So yes, what I'll be speaking about now is a clinical perspective. I'm a radiation oncologist at Yale. I focus on lung cancer mostly. Here are my disclosures. None are really relevant to this talk. So extensive stage small cell lung cancer is usually quite aggressive and very fatal for most patients. About 70% of patients with small cell lung cancer present with extensive stage disease, meaning that they usually have metastases in some area of the body that's outside the lungs, typically in the liver, adrenal, or brain. So the survival tends to be a median of around a year, but then there are some more 5-year survivors these days, but it's something that is still fairly uncommon. This here is from you'll see this article in JAMA that's coming out hopefully pretty soon from So-Yeon Kim, one of the medical oncologists at Yale. So until 2017, we really considered chemotherapy to be the main standard of care for this. It was really palliative. The question was whether we can add thoracic radiation therapy. So this came here from the CREST trial that was published in Lancet in 2015 from Ben Slotman and others over in Amsterdam. But what they did here was they took about 500 patients who had at least a partial response to first-line chemotherapy and randomized them to thoracic radiation versus observation afterwards. Thoracic radiation was given as 30 gray and 10 fractions. You noticed a trend for improved overall survival for all patients, with a hazard ratio of 0.84, but confidence interval crossing 1 point, that just crossed over 1. So at the 1 year overall survival point, this was not statistically significant, and this was this was the primary endpoint. However, on post-hoc analysis, they noticed that the 2-year overall survival was quite different, 13% versus 3%, with a p of 0.004. This difference was also significant when you look at 18 months as well. So the thought was that potentially this, even though this didn't impact the short-term survival, there maybe were longer-term survivors who did get consolidated radiation, and maybe there was a select group of patients who might benefit from this. This also showed some improvement in progression-free survival and intrathoracic control as well. But this wasn't very impressive, but it was enough to suggest with no real other advances in extensive stage small cell lung cancer that this could really be, this could be a treatment that could be useful. So after 2018, some of the trials came out that showed that when you add chemotherapy and immune therapy together, then this really would improve outcomes as well. Progression-free survival and overall survival improved by a median of about 2 months. And again, not huge, but the idea again was that there may be some longer-term survivors, and even though the percentage was small, that there was still a chance you might get some long-term survivors from this. So there's an active trial right now in the US called NRG-LU007, which is the Raptor trial. The basic idea here is that they're in the era of chemo and immunotherapy. I should backtrack to say that in the first trials that showed that immunotherapy is helpful, they did not allow for inclusion of thoracic radiation, despite the CREST trial results. So really this Raptor study is trying to assess that question again now in terms of consolidated radiation, now with the backbone of chemotherapy and immune therapy together. This one allows not only thoracic radiation, but also to allow for radiation at other sites. However, we don't expect results for several years. It's slowly accruing, the phase 2 component, and if it gets to phase 3, that'll take even longer. So what do we do until then, when we don't have this information from clinical trials to help us in the setting of a new standard of care, systemic therapy? So what we did was we started looking at the Flatiron data. This Flatiron company, they involved 3.2 million active patients. They have almost 300 cancer clinics and 8 academic partners. And what they do is they'll be able to acquire data from all these centers and then be able to feed it back into a few academic partners to be able to analyze. They have several disease sites here, but what I'll be focusing on here is small cell lung cancer. So, what we set out to do actually was, the story I'm going to tell was not necessarily meant to look at sex as a variable up front, which I know is the topic of this talk, but this is something that we kind of ran into as we did our analysis. But the real initial goal here was to determine whether radiation would actually benefit more of those who receive chemotherapy as a backbone. Again, the pre-2017 era work where the CREST trial came from, or if it was more in the patients that got chemo and immunotherapy for extensive stage small cell lung cancer. And to see if we still saw the same benefit or less so, to see if there's still equipoise in this area about whether or not we should be using consolidated radiation in this setting. However, as we were doing the analysis, we noticed that the proportional hazard assumption was violated. So when we broke it down by those getting chemotherapy in all years, we saw the hazard ratio of 0.83, confidence intervals 0.68 to 1. But when we did the cost proportional hazards model, really wasn't working out with the assumption of proportional hazards. And we found that the violation was because of sex. So then when we actually did a stratified analysis after that, based on males versus females, we noticed, there's 0.94 hazard ratio and confidence interval crossing 1 to 1.24. Whereas for females, we did see that it was 0.68 and confidence interval going from 0.51 to 0.9. Similar to the chemoimmunotherapy arm, we saw the hazard ratios were actually even more extreme, with males actually over 1 in this case, although this was not statistically significant. And females, the hazard ratio was actually less, but the sample size was less as well. So the confidence interval crossed 1 here, but still in the same direction, which we thought was quite interesting, and something that we were actually quite disappointed by, because we didn't see any we didn't know of any biologic basis for this, and we wondered, why is this happening, and why can we basically not do the study that we set out to do originally? But then when we broke it down further, we found this more and more interesting, which is that the patients who were female actually had much higher overall survival on the left, and also higher progression-free survival on the right. Which was, actually, this really was very substantial. At 12 months, you can see this is probably at least a 10 to 15% absolute difference in overall survival. So then we went back and looked at the CREST data again. And there was a subgroup analysis in the original paper from the Lancet Oncology that showed that men had a hazard ratio of 1.01, and women 0.68. With a p-value of 0.06. So we actually reached out to Dr. Slotman to ask, what do you make of this? Because we're seeing some very similar findings here. Again, here from the first analysis, we have a higher N for each one. This is, of course, retrospective, yet we saw 0.94 in males and 0.68, exactly the same hazard ratio in females. So we said, is there something here? And he said, maybe. They didn't really have much more insight into it than that, but they did notice that. But because the p-value was 0.06 and it was not a pre-specified analysis, they were actually encouraged from the journal not to explore that any further in the paper. So this was something that we decided to collaborate on this, and that's actually how once we published this paper, we actually met Laure through that. And we're able to start our own collaborations. So here's some forest plots here of just showing that basically when you look at we can look at the unweighted part, because we also did this other analysis for weighted analysis with inverse probability weighting. But the main message is the same, which is that essentially for males in overall survival and in progression-free survival, you see the hazard ratio around 1 or even higher than 1. And this was the idea of is radiation predictive, or is sex predictive of a radiation benefit. So this is no longer looking at the prognosis of just how are patients doing overall, but the question here is when is there a higher chance of radiation, consolidated radiation, having a benefit among males versus females? You can see a very stark difference here in both overall survival and progression-free survival down here, where males really were right around 1 or even higher than 1, and then women were right around that 0.6, 0.7 range here. So we've known to some degree that sex is prognostic in small cell lung cancer and non-small cell lung cancer. We have some articles that have been published in the past several years on this. But really what was not known was whether sex is predictive of response to treatment, specifically radiation or potentially other treatments as well. So some possible explanations that we thought at the time were, is it that there's unmeasured confounders here? Is it that women have a lower disease burden that we can't measure, such as tumor bulk, the number of metastases, the volume of metastases, etc. Is it that women have less smoking history and maybe have less aggressive disease because of that? Or is it that because we notice that women live longer than men, is it that they are more likely to realize the benefit of consolidated radiation, given that they're more likely to have extended survivals? So those, if you're going to die soon anyway, then potentially the benefit of radiation doesn't help so much. But for those who would have been long-term survivors, perhaps you're able to turn even more of those into longer-term survivors as well. Is it that women have a better response to first-line chemotherapy plus minus immunotherapy for any reason? Or any of these above reasons or others, or do women have some kind of different mutational profile or chromosomal differences or something like that? So we really had a hard time getting this published at first because we the main question that was asked was, do you really believe this, right? Do you really think that this makes any sense biologically? So then we met. Really after that, then it was really amazing to be able to meet Laure and discuss the biological work that she's been doing on this that suggests that potentially there is this link that may that actually may go beyond sociodemographic issues. So we have some ongoing work currently. I'm just introducing this topic, which we're just starting now. But the precursor to this can start as more of a clinical question for non-small cell lung cancer. Now we're making a much more movement for those who are getting surgery for locally advanced non-small cell lung cancer to be getting different kinds of neoadjuvant therapy. So standard for a long time has been either chemotherapy or chemoradiation prior to surgery. And then more recently, there have been multiple clinical trials showing that chemo and immunotherapy together may lead to the best pathologic complete response over chemo alone. However, there really hasn't been a comparison against chemoradiation. So we went, with the Flatiron study with the early stage database, which had much fewer patients in it. But for the patients that we did see, we noticed that the pathologic complete response was overall very similar, 39% for both chemo and immunotherapy and 39% for chemo and radiation versus 10% for chemotherapy alone. And we noticed that pathologic complete response seemed to correlate also with progression-free survival. As an endpoint. So this is work that's in submission currently. But now with our collaboration currently, what we're hoping to do now is use a similar cohort to now investigate overall survival, progression-free survival, and pathologic complete response among between male and female patients specifically, to see how they're doing prognostically in terms of differences between the sexes in terms of their outcomes, but also how whether or not sex is predictive of a benefit or differential benefit of chemoradiation or of a benefit for chemoimmunotherapy. So this is work that we just got the data for and are currently working on. So that's all I have today. So I just wanted to introduce you to that the clinical application of the work you've been hearing from Dr. Marignol, and I hope that this can lead to some further discussions on how we can work together from the clinical and the research side in order to really get some really interesting new insights into the possibility of a link between sex and outcomes after radiation therapy and other treatments for cancer. So thank you very much.
Thank you, Henry, and thank you, Laure. It was it's great to get the two arms of the kind of problem, or the two angles, or the perspectives from both angles, I suppose, in one presentation. So just for any participants, please feel free to use the Q&A box to pop any questions in there. The chat doesn't work in the webinar format, but you can pop any questions there. And I suppose just while we're waiting, I suppose I was just sort of thinking on a practical level, like, what do you think we could possibly or should be doing now, maybe in the context of clinical trials? Like, do you think we're at the stage where it should be considered in clinical trial design, or is that a little bit down the line yet?
Yeah, that's actually one of the conclusions we had, was that potentially we should consider sex as a stratification variable, right? That even though we wouldn't, so I've gotten the question, should we only treat women with consolidated radiation and not men yet? And I'm not sure we're there yet, right? Again, we need the clinical trial data, I think, to suggest that. But if we could do this, as a pre-specified analysis, right, and actually balance the arms, with sex, which may come out that way anyway, but at least to do a pre-specified analysis rather than post-hoc, that may be more meaningful as well. So, I think it's too late for the Raptor study to, change their approach to it currently, as they've already been accruing. But something I'll I think for future studies, we should certainly consider. I think the more compelling data we have on it over time, then this may be something that will be really considered for future clinical trials, or should be considered.
I suppose that's a quite low impact way to start looking at it too. You're really just balancing the arms in advance as opposed to post-hoc looking at it. Yeah. And from the kind of clinical research, the radiobiology side, Laura, do you think there's things that we should be doing at the moment, like in terms of cell lines, or is it possible to balance in that scenario?
I think there is value in designing experiments having a female cell line and a male cell line, and I think we don't perhaps always check. We just get the cell line because they're coded, and we don't necessarily go in and check, are they male, from a male patient or a female patient. So maybe trying to at least have both sexes represented is a first step. I think in cell lines, it's quite challenging because it can be difficult. It's only like n equal 1, it's one representation of one patient. So it can be very difficult to say whether the effect you see is really due to sex or is it due to something else. So there are some challenges there. And that's why I think looking for biological markers specific to sex might help us make those links. I think in animal studies, it's to also be careful of, what you put in those mice, what sex they might be, and maybe chop and change the sex of the mice itself. And what's really slowing effort is sometimes it's not even reported in the literature. So when you read you do your research to design your study and you read about what others have done, it's not always known. It's not the information is not there. I think if we start to report it more, it's going to make life easier. And then in patient specimens, and it's quite expensive to do, it's add another layer, but to systematically profile the tumor samples to be aware, because a patient might tick a box, male or female, biologically, at birth, but their tumor may no longer be, because maybe they've lost a Y chromosome if they're a man, or their X chromosomes are not the same in their tumors and the body. So I think having this information captured will help the accuracy of what we test, and it's quite a challenge at the moment. And what I think was very nice in Henry's study is perhaps this did see the effect because the two arms were so well balanced. So your patient numbers in each between male and female are quite similar. And what we see in clinical studies is that often they're not. And investigators can be telling us, well, it's because this is more prevalent in men. So of course, I will have more men in my clinical trial, which is a valid point. But in not correcting for that in the study design, perhaps then you're preventing those effects to be detected. So as we just discussed, if that was part of the trial to make sure we end up with a balanced representation, should help, I suppose, identify those effects.
I think it's really interesting that you said that, and I didn't know this before you talked, that the tumor can have a different biological sex, or the biological sex can be changed. And I think that really, to my mind, raises the question of like, well, what's the important bit here? The like biological sex of the patient, or the like tumor cells? And is it the, like, as you said, sort of the impact of hormones and that kind of microenvironment, the biological microenvironment, or is it the like actual tumor biology and genetics that like will make a difference? And I think that might be also kind of an interesting thing to consider in the future. Like, I suppose it just brings to mind like immunotherapy, where some of it, the response is to do with the immune system as opposed to the tumor's kind of microenvironment, So I think we have no questions in the Q&A. We're very quiet participants.
I've done a good job, Henry.
Yeah, you've covered everything. Well, look, I'm going to take the opportunity again to thank you both for your time and that really kind of helpful and exciting overview. I think it raises a lot of questions and a lot of food for thought, I think, for future work in any of the kind of sites where it's like across male and female cohorts. So it's quite exciting. So we look forward to watching this space and seeing what comes next from your collaboration. So thanks for sharing this intro with us.
Thank you.
Thank you for the invitation. I really appreciate it.
Yeah.
Take care.
Bye.